And we meet quarterly. We're a little bit late in meeting this time, but this is our quarter 3 meeting. And just to say, if you know other people that would like to join the group, I'll share the Wessex Cancer Alliance email address in the chat at some point, so you can just pass it on to them and they can sign up. We also have a website which I'll share as well. So in the terms of kind of interaction, you can use the chat, or we'll have time for kind of questions, so you can raise your hands at the end. And as I said, we'll be recording. So if you don't want to be on the recording, just switch your camera off. So probably going to hand over to our speakers now. So I'm going to welcome our 2 speakers. I know Dr. Afsana Bhuiya is on the call, so I'm going to hand over to her to introduce herself and talk about this topic, which is something that's really kind of dear to my heart, coding. I think coding in the context of cancer in primary care has been a really tricky thing to get right. And I think we're still struggling with it. And with the recent QoF change, I'm really concerned that actually coding isn't going to improve without intervention to try and make it happen. So really pleased that Afsana could make it today and present some really great work that's happening in North Central London. So I'm going to hand over to you now, Afsana. Do you want me to unshare and reshare?
Is that okay? Yeah, then I can just move at my pace. Thank you. Thanks, Sandra. Thanks for that lovely introduction. So really pleased to be here. I just wanted to say we are, so Graham and I have been doing a roadshow for this particular project. So there may be some people who will join the national team. So apologies if you're hearing this for the 50th time. You know, you have the option of not listening again if you want to. So anyway, I will slide share now and put this on presenter mode. Just let me know if you can. If you've got the sight of the slides now.
They're just loading at the moment. No, they're up now, yeah.
So I'm Afsana, I'm a GP and I work in North Central London. I'm the clinical lead in the North Central London Cancer Alliance for Innovation and Integration. I've been working there for a number of years, leading on lots of different projects. And this is the current project that we're really excited to bring to you. And I've been working alongside our program lead for the analytical aspect of our team, Graham, and so really, you know, want to showcase some of the things that we have unpicked, discovered, but also recommendations that we are in the process of implementing. So when I talk about coding, you know, often it does feel quite detached and tedious. You know, people don't often make that linkage with its real kind of direct and indirect impact with patient care and safety. So I think it's really important to kind of start off like why it's so relevant. And so we put together the slide that really shows, you know, it's the heart of the issue really when it comes to clinical record keeping and I suppose how we manage our population. So there's a couple of quotes here that I wanted to just start the conversation with. So one is that I was eligible for a lung health check, but no one knew I was a smoker. It wasn't coded. It was mentioned in an old consultation that would have been in the free text. So flagging up a few more that have come up in our journey thus far. So my breast cancer family history wasn't known about, and hence I wasn't referred to the genetics clinic. My cancer treatment wasn't coded, so I wasn't identified as high risk and in need of a 3rd COVID vaccination. And we've got quite a few more. I won't read all of them, but those are sort of the pink ones are kind of direct care, and the green ones are more about actually poor coding risk. Factors like smoking and family history limits our ability to identify at-risk populations, and this hampers our prevention efforts. So this sort of sets the stage for our conversation. So I hope that sets the scene for why it's important to get coding right. Accurate coding is essential for safe, personalised and effective cancer care. What you're seeing on this slide, and I apologise, it's a busy slide, is really a way to construct how the different ways that we use coding. So it's on the left, you've got this impact on direct patient care, and then the bits that probably we do within the health service management side. So its impact on service planning and improvement, all the way down to the other side where you've got to where it can impact on researchers and people wanting to research and development, and in that context. Okay, so how did we broach this? So we knew we had to sort of frame a problem statement and develop that case for change. So really early on, we had this sort of shared hypothesis, and this is about 2 years ago, so back in 2023. that actually, do you know what, primary care data is suboptimal. We hear that a lot from our clinical conversations and different projects that we're trying to roll out. And the Cancer Alliance was like, well, we need to sort this out. We need to fix it. But actually, one of the key things we needed to know was, well, actually, how bad is it and where is it bad? And then once we know that, what are the options to fix this problem? And just so people know, there was a bit more context at this time. So what was happening in NCL, or what is happening in NCL, in secondary care to resolve this problem, was kind of deployment of more innovative solutions, so large language models, machine learning, to kind of really be able to auto code, rewrite codes into clinical records within the hospital setting. So with that in mind, we then started to frame that kind of case for change and think about what it is that we needed to do to broach this problem. So we started with our literature review, and really, in summary, what we discovered was that the existing evidence on this topic was limited. It was quite heterogeneous, really difficult to get a granular enough understanding of what coding was like across the cancer pathway in primary care. There's lots of data on coding, but it's not necessarily framed in primary care, definitely not framed in the context of all of the different data parameters that we would be interested in. And so really, we had to, our starting point was, well, we need to improve that status quo. So I'll hand over to Graham, who's really going to give us as a group a bit more about actually what are those drivers for why the data could be the way it is and why it's so different to secondary care. So is that okay, Graham?
Yeah, sure. That's a very familiar slide. Thanks, Afsana. So what drives the quality and completeness of data in primary care, and how does it differ specifically from secondary care? So I think it's fair to say that secondary care benefits from having well-defined mandatory data sets where data is routinely fed out of providers into NHSE that generate all the cancer statistics that we know and love. Of course, SUS data that covers all the inpatient and outpatient emergency episodes of care for patients at trust, that's the biggest. But for us in cancer, specifically data sets like the cancer waiting times data set and COSD, the cancer outcomes and services data set, where all the diagnosis and staging information is held, and most relevant. All very well established, structured data sets with quality assurance based submission processes, mandatory data items, really well-defined data formats, etc. Submitting this data and these data sets, they're part of trust commissioning contracts, and there are targets in place for things like cancer waiting times as well for trusts and systems to aim at, of course. So all really well established, and we have access to real good commissioning data from secondary care. It's fair to say that there isn't the same routine data flow out of primary care for anything that's really related to cancer. Or high-profile KPIs or performance indicators. It's pretty much the opposite to what it is in secondary care. We have had the quality outcomes framework, of course, over the last few years, which you mentioned earlier on. It's provided that financial incentive for recording specific conditions or activities in primary care systems, which of course has helped the data completeness. A number of cancer indicators, as Sandra mentioned earlier, has reduced in QI in 25-26, for example, the recording of the cancer care reviews in primary care at 3 and 12 months post cancer diagnosis has dropped off, which is a real shame. QI also only covers a small part of the overall cancer pathway. Things like cancer staging and treatments and any living with and beyond cancer metrics, such as the health needs assessments completed, none of those are part of QI. And while much of that information sits in secondary care systems, of course, it doesn't routinely make its way back into primary care, as Afsana mentioned earlier on, which we'll talk about a little bit more later. And this sort of lack of process and governance, I suppose, it just leads to the variable data completeness that you get across cancer indicators in primary care. Example being that I like to give is capturing a patient's cancer diagnosis. It is part of QI, and practices are incentivized to collect that. Data completeness is quite good, therefore, when you compare that to other data sources where cancer diagnosis is captured, such as the rapid cancer registration data. But as cancer treatments aren't part of QI, the data completeness is extremely low compared to treatments that are captured in cancer waiting times. So that means that a GP can obviously see a patient has been diagnosed with cancer, but has an incomplete or completely missing, perhaps, picture of the treatments that patient has had. So it just makes organising a follow-up so much more time-consuming. think fundamentally as well, primary and secondary care, they use different coding terminologies. Of course, SNOMED CT in primary care, and it's ICD-10 codes and OPCS and HRG coding in secondary care, which aren't like for like. And although there are mappings that have been developed that translate between terminologies, we don't routinely employ these currently in primary care. We're not that sort of digitally advanced. Coding is just a very highly manual process. You know, a coder basically picks up a diagnosis or an ICD-10 code that they may not have seen before from clinical correspondence from trusts or other healthcare organizations, then having to search the SNOMED CT browser for coding options. Sometimes you'll find there's very similar codes that you've got. So you've got a bit of a choice now, which one am I going to choose, etc. It's just a sort of long-winded administrative process for staff. And whilst there are established processes in place in secondary care for like regular coding, inspections and audits of clinical coding data and standards, primary care, it's not included in any NHS coding audits currently. So of course, you know, the quality and completeness is not going to be to the same standard as secondary care. Do we go on to the next slide?
Yeah, I'm just stuck.
Sorry.
There we go.
Yeah, got it. And we've listed out here the barriers as we see them and as the project showed to high quality clinical code. A few of which I've already touched on, such as the financial incentives and the lack of coding standards. As I mentioned, coding, it's a highly sort of manual process, and practices, you know, they don't have dedicated roles, of course, to code all these activities that get included in the correspondence it receives on its patients. Staff are generally juggling multiple responsibilities, and there's just little automation or use of software or digital tools to support code capture. Having the sort of time and level of knowledge and experience to manually code effectively and efficiently just isn't that widespread across primary care. Very, very limited automated data transfer into primary care systems. We have EMIS in NCL, and it doesn't have a lot of digital solutions to inbound data from other healthcare organizations at the moment. SNOMED CT itself is extremely complex, as you'll all know, and there's a lot of overlapping codes, particularly when it comes to capturing diagnosis, I mentioned earlier on, and particularly for those less common cancers. Trying to code those accurately, you know, is an absolute pain. The manual nature of the coding in primary care as well. It just, I mean, I suppose it just feels really behind the times when we're thinking about the 10-year health plan and going from analog to digital. I mean, there's like a massive opportunity here to potentially turn, you know, what's currently a little bit of a negative into a positive, I think, and that's our opinion. So I'll seamlessly hand back to you, Afsana, to the next section.
Oh, brilliant. Thank you so much, Graham. Really helpful. So this slide just gives you a bit of an overview of where we started in 2023, where we are now, and I'm going to take you through the next bit of the talk, some of those steps. So let's progress forward. So really what we needed to do was fill that evidence gap in order to then come up with some options appraisals and how you make it better. And so we conducted this quality improvement, which was essentially a mixed methods QI project, which involved a large observational data set review, and that was married up with qualitative data to validate the findings. And we did that within North Central London, just so that group are aware. In North Central London, we have one electronic healthcare provider, EMIS Web, for all of the GP surgeries. And for us, that's about a population of 1.4 million across the 5 boroughs. And our overarching aims really, let's look at the quality of clinical coding, and let's look at it across the whole cancer pathway. So all the way from kind of the traditional ways that this group will understand, you know, from prevention awareness to referrals to treatment and living with and beyond. And then we wanted to develop and have developed recommendations based on what we've unpicked from that work. So there's the next few slides go into granularity of the method, so I won't dwell too much on them, but pluck out some key bits. So in terms of approaching the quantitative data collection analysis, so essentially we worked with a federation provider who helped us build these things called searches, which is a way of extracting coded data across primary care systems in North Central London. And we looked at established frameworks that look at coding quality, and kind of took a I suppose comprehensive but diplomatic approach to how we would then define that within the context we were working in. And so we picked on these 4 dimensions, and the key ones really for this group around coding completion, diversity, and then validating that against established data sets. And when it came to qualitative data collection and analysis, we used a variety of methods. So we held two large workshops, but we had interviews, we had email interactions. So we looked at all of that data to help us understand the quant data, and we used a method called framework analysis to analyze that data. Right, so in terms of, let's have a look at the results. So our report, the work that we've done is quite extensive, and there were a huge number of data parameters, and so we had to chunk it up. And to make it easier, we themed them into kind of, I suppose, really key themes that we were seeing. So the pre-cancer section, and screening, and then post-cancer. And within the theme 1, theme 2, theme 3, you can see we've subdivided that into, I think we've got some background noise, haven't we, Sandra? We've got where data's curated. So data curated in GP practice or not, or in secondary care or in other places. And that's how we then present the results back to the group. So within that pre-cancer space, which is theme 1, lots of things we unpicked. I'm just going to pluck the highlights out so that we can focus on the key things that's of importance to this group. So we saw things like ethnicity coding was really high, 86.5%, and actually it wasn't a huge surprise when we'd learned that obviously there was a PCN DARES that was funding practices to actually code this data prior to the data set being run. So that was helpful to know. And then other areas that are of interest are things like looking at environmental exposure codes, where we'd seen completeness of 0.04%, so really low. And then let's pluck another one, like employment status coding, where again, really low levels of coding completeness, so 2.4%, but really interesting, like when you do have such low levels, that you can actually still use a suite of codes to describe things. So we saw 87 distinct codes in that coding dimension. Let's have a look at some of the key things from the qualitative findings in theme 1. So the key things really that stood out for us were opportunities to collect and update data. And so stakeholders sort of talked about, actually, we need to standardize this. We need to have better ways of collecting data and better sharing. And then motivations and capacity came up. So coding driven by QOF, so that's the financial incentive that we're all familiar with in primary care, to local schemes versus where there's no incentives. And actually, then coding then tends to focus on things that are relevant to immediate clinical interactions. And then the last big theme was around system and processes. So the theme of variation because of manual. Then there's the concept of automation, which we have heard practices are starting to do. It's just not universal. And then other opportunities around automation and streamlining coding prompts were recommended by some of the groups. In terms of theme 2, which was the screening pathway, so we looked at coded data along breast, bowel, and cervical. The key one for us really was around breast screening uptake. That was fundamentally stood out for a number of reasons. So one, the uptake recorded was variable, with a 12% deficit compared to the comparator database. And we saw 30 unique codes were used to document breast screening activity. In terms of the things that came up, again, they were by large about the breast cancer pathway. And if anyone's familiar with it, that's quite an outlier compared to how the other 2 screening pathways interface with primary care and how those are funded. But essentially, lots of comments around breast screening processes. So the fact that it's still paper, there's 2 patients per sheet, it's a time-consuming process to extract that data, the fact that there's actually no mandated standard codes from top down. It's people were using different codes to code a simple activity like attended breast screening or did not attend, and that's quite different to the other screening pathways. And the other thing to note is that coding of screening attendance is inconsistent. It's driven by kind of QOF, and many GPs see that screening attendance is a responsibility of national programs and not primary. And so that thing around actually whose responsibility is it? Is it really up to us to improve that? And which is a fair challenge, of course. So that's theme 2. Theme 3 was around from cancer diagnosis to then onward care in the community. So things like staging, treatment, follow-up, surveillance pathways. So lots of things to see there, lots of missingness in this part of the pathway. So Graham mentioned that earlier on that QoF does incentivize primary care to code cancer diagnosis, and we did see pretty good completeness there. But despite that, the fact that it's funded, there was still a 13% gap. So, we feel there's still an opportunity there for improvement. But the other things were huge gaps. So things like cancer staging, cancer treatment was 0 to 2%. And then your wider personalized care indicators. So things like cancer care reviews, obviously funded by QoF, were pretty complete, but anything outside of that had pretty low levels of completeness. And in terms of the qualitative themes in this part of the pathway, so questioning of the relevance to clinical workflow. So is coding of post-cancer diagnosis data is not seen as a priority, and it's not necessarily incentivized. There was discussions about quality of information sharing. Again, a really, really interesting one that came up. So the fact that actually there's a lot of information going into primary care, but it's in an unstructured format and it's buried in letters, and there's no technological solution to kind of be able to extract that data, get it into GP practice notes, so that people can read it without having to open up another system and look at a letter. And that then relays into system complexity and inconsistency. So coding quality varies by practice depending on whether the trained coding staff are in place. So let's bring that all together and this discussion slide. So really what this does bring together much of the areas that I've talked about, but in summary, really, we've seen a huge variation, some bits not surprising, some bits a little bit of the surprising, but essentially large gaps and lots of missingness, where you've got huge completeness, where you've got your incentives like ethnicity or cancer diagnosis, all the way down to the wider factors, particularly in the early bit of the pathway and the latter bit of the pathway, where the data isn't necessarily always curated in primary care. We've seen that cancer screening data varied hugely, and breast being the outlier. And really, the things that we would want to then build on is actually what can we do? What can we say to the system about recommendations? So for moving forward, and so some of those key things I'll put on here, such as can we standardise registration forms and health check appointments? Where we've got financial incentives like QoF, what other ways can we incentivise a system to improve the coding? So let's now move on to looking at some of those recommendations, because we've been working on the first one. So I'll hand over to Graham again. Is that okay to take us through the next couple of slides?
Well, I'd love to. So the conclusions from all this work then, do you want to pop onto the next one? There we go. The main one being that we obviously need to improve the data infrastructure in primary care, and the first step towards that is the development of a cancer minimum data set for primary care that covers the sociodemographic and cancer-specific indicators that matter, where we can suggest distinct code sets and codes to capture all the activities in SNOMED CT, develop templates in EMIS that allow for a sort of slick data capture to an MDS standard of our suggested indicators. And we have developed and published this. The MDS or MDS, it aligns with data quality and completeness drivers in secondary care. And if data collection in primary care starts to conform to MDS standards in NCL, our analytical capability increases, which is what excites me the most being an analyst. So we've been developing the MDS since last summer, engaging with various clinical and digital teams across primary care. It's been quite broad, actually. Colleagues both in the Cancer Alliance, but also IG colleagues across NCL, GPs, of course, EMIS themselves have been part of this process. The One London team as well, for those who are familiar with that work, and the work they've been doing around the London secure data environment, the London data service, GP IT teams and analytical teams at the ICB. There's been an awful lot of engagement, and that culminated with a workshop that we ran back in March. It was attended by representatives pretty much across all of that sort of stakeholder base that I've just described, with to basically endorse our approach and the development of a minimum data set, which received complete support an approval within that workshop to publish. Do you want to go to the next slide? Yeah, and we've now done that. The first version of the MDS is available online via our Cancer Alliance website. We've got the link on the slide there, and on the website there's easy reads and technical guides of the MDS, which sort of lists the data items and suggested codes in SNOMED CT that we want people to use. And as I mentioned before, we developed this with the GPIT team at our ICB. So there's a data collection template that conforms to MDS standards, which is a great tool for users to really get on board with the MDS. And through this process, we did identify a number of areas. I think it's worth pointing out where SNOMED CT codes existed, but EMIS had not pulled them into their product from the wider SNOMED CT library. So having EMIS involved in the process allowed us to engage with them to bring through codes that existed but weren't available in EMIS for our users to select, which was really good. And we also found a number of areas where there are not specific SNOMED codes currently within the SNOMED CT library, such as cancer MDT specific discussions, tumor specific stratified follow-up pathways, and surveillance of pre-cancerous conditions like Barrett's esophagus. So we've flagged these to the SNOMED editorial team at NHS England, and we're trying to work with the cancer programme to bring those for consideration, which is a little bit of a process. On the next slide. Yeah, beyond developing the MDS, we had 8 other recommendations that came out of the project, some of which we have direct influence to tackle and progress, and others that we don't, and we'll have to see how we can influence external bodies and policies in time. A few of these we've already touched on, but I'll summarize. A key one that we would want to highlight on this slide is number 3, improving secondary to primary care data flows. It's a case of, can we better standardize correspondence between secondary care and primary care, and even move towards interoperability where hospital PAS systems could potentially send information and messages and data directly into primary care systems. Automation and natural language processing could really reduce the amount of manual coding that's happening in primary care and have a real positive impact on the data quality and completeness and availability in primary care. We're really passionate to try and find a way to crack this one, and we've got a number of conversations that we've kicked off recently. We're also, as Afsana mentioned earlier on, looking to enhance the breast screening data integration with primary care, and we've initiated conversations locally with our breast screening service to standardise or attempt to standardise the breast screening activity coding. They are mapping their activities to, and how we can streamline the data transfer and help our coders code more efficiently. Standardizing coding practices in primary care using the MDS as a vehicle, that's going to be a great step forward. But as Afsana mentioned earlier on, employing more coding experts in primary care, that would really help embed best practice as it develops and support potential digitization as well of coding processes. And having those type of roles, or more of those type of roles in establishment, would really help raise the profile of coding in primary care. I know it's a big ask in the current financial circumstances, but one we're really passionate about. And optimizing the registration process as well. The PRF1 registration form that captures the majority of the socio-demographic and risk factors data points that the project had highlighted, and it's a really good tool to be able to build a complete picture of a patient from the outset. Can we promote and support adoption and uptake of the PRF1 registration form across our GP practices in NCL? We're certainly going to try our level best. Do you want to go on to the next slide, Afsana?
Yeah, it's got stuck again. How does it do that? There we go. Yeah.
Eureka. Right. Other recommendations on this slide, a couple of which we've already touched on, such as number 6, influencing QoF to include more elements of the cancer pathway as part of the scheme, and instituting the funding coded audits, number 7, the things that we can't directly influence, but they are conversations that we do want to find ways to initiate and drive if we can through socializing the work as we are doing today. Within our scope, though, is the development of an analytics dashboard, which is a project that we've recently started in NCL using NCLGP data to develop a population health management tool, which will allow us to robustly case find in the future, and also track data quality and completeness of our MDS data items and indicators, which will help further embed the minimum data set into standard business practices and highlight areas of quality improvement, potential quality improvement initiatives to try and drive up that the data completeness across data items. And we do want to share, on the final point, we do want to share the learning from this project across cancer alliances and ICB footprints, regions, etc. Some areas of the country already have much stronger data and coding completeness in primary care than we do in NCL. So there are other systems that we can learn from by spreading the successful approaches more widely and sharing that information between us. We can hopefully improve both the quality of the data, but eventually that'll be an improvement, hopefully, to direct care for patients as well. Fingers crossed, maybe at scale. Yeah, back to you, Afsana, I think, for the next section.
Oh, brilliant. Thank you. So really just to summarise, does coding matter? I mean, I really hope the group agrees with us that we think it does matter. Yeah. We bring it back to where we began, which is actually this is about direct care as well as indirect care. And actually it does have direct implications on the patient's journey and the patient's safety and wider as well. So what's next? So you've heard hints of what's next and what we've done thus far. So obviously we are on a roadshow publicising, socialising the dataset review, but also one of the first outputs, which is the MDS. And obviously, of course, really happy to share the slides, but also we can put the links in for the MDS, which is on our NCL Cancer Alliance website. We've got these wider recommendations that Graham and I are taking a kind of multifaceted approach to target, but just to highlight again those early wins. So we have managed to convince EMIS Web to turn on hundreds of SNOMED codes for free within our within the electronic healthcare system. Obviously, that doesn't just benefit NCL, that benefits anyone across the country in the NHS who has EMIS Web. So I think that's really great. We're working with Peter Johnson and his team around trying to get these new codes codes created, which is, it's a significant barrier and it's a slow process, but we're going to chip away at that. And one of the things that's near completion is one of our really kind of low-level implementation strategies, which is an MDS template with it sits in EMIS Web. We don't expect every GP or practice to suddenly use that to code, but we think it's one of many interventions to start enabling that process of coding and seeing some completeness in the coding. And so really, I think the key things that this group might want to think about or could support us with is obviously within your own geographies and the projects that you're doing, having the awareness of the data curation issues. We don't think that these issues are unique to North Central London, even though we've shown you this through the lens of EMIS Web. We don't think that the other primary care systems are a whole heap better, or that GPs' behaviours will be vastly different across the country, because we know that the national drivers within the NHS context are the same. And the second thing is factoring the work into programmes that you're doing locally. And the biggie for us that Graham's obviously mentioned a few times is actually the key implementation strategies. How can we get the data that we know that's there within secondary care actually automated and coded, and so there is clear information and flow and transactional flow and coding, and we really see that as more kind of national solutions, which we are progressing with the National Cancer team, but it's more just to make people aware. And obviously, if you are developing your own local solutions that you've not let anyone else know about, come and talk to us. So yeah, that's pretty much where we're at with it. So really happy to take questions or further thoughts. Over to you, Sandra.
Yeah, thank you, Afsana and Graham. It was really, really interesting presentation and raises lots of questions in my head. But be good to hear from the group as well. But before we do, I had a quick question about the translation of what you've done in North Central London nationally. Is if people wanted to use your minimum data sets, would that automatically translate, or does that need work to translate to a local context?
Yeah, so no, if you're within, so the minimum data set that we've published is it's a Word and Excel document. So you've got the technical document in Word, so anyone could go away and use that. What we've developed as a automated way to decode the data is within EMIS Web, because that's our system. So we've developed something called a template that you can upload, and it basically copies all of the MDS recommendations into that template, so GPs don't actually have to look for codes. They would just tick it, or if they slotted a letter, they could select things. Does that make sense? What we haven't got to stage is where we're doing that for the other two major providers, which I can't remember the names of now, Vision and something else.
System one,
that's it. So Vision System 1. So obviously these are additional bits of work that we imagine may come out across, as you know, it's a bit of a chronological order thing. You need to sort of do for the first bits of the project, and then if these things have buy-in, but ultimately, as I said, our key strategy for coding solution isn't really about templates. It is about that kind of system level solution, automation, and AI solutions. So yeah, does that help?
Yeah, thank you. And there's a question in the chat actually. I think you might have answered just now, but I'll ask it just in case I'm missing anything. So, have you found issues of coding crossing over between System 1 and EMIS when patients have changed practices or run different software programs? So, thinking about, I guess, the sort of more mobile populations, is there a fix for that at the moment? Or not?
So obviously we've done this work in EMIS Web. So I'm going to look for parallels, because we don't know that, because we've not done that bit yet. But when you look at patients moving from System 1 to EMIS 1, what we see as GPs for their general histories, that coded data does come through, because they use the same coding terminology. They use SNOMED CT. And so the premise of our MDS is using SNOMED CT, which is the language within the coding language within primary care. I don't envision that being an issue. There's obviously other wider issues around how free text looks, how attachments come across. But I think generally when you look at patients, who've got diabetes or other sorts of diseases, I haven't to this date noted that there's a huge issue with missingness with codes if it's coded.
Okay, thank you. Does that answer your question, I presume, Pip? She can let us know otherwise.
Yeah,
There's one. Okay, thanks. One other question in the chat from Amanda Watson's asking who you've spoken to in the cancer program in relation to the PSFU coding. Maybe you two can connect.
Yeah, definitely. Do drop us an email, but essentially it's Peter Johnson who's taking the lead as the National Cancer Clinical Director for all of the codes that we've requested. If you look at our MDS, so all the codes are obviously aligned with what the national strategic codes are anyway, from lung screening that are missing to stratified follow-up. And as I said, it's, as Graham mentioned, the development of the MDS was through that co-design process with multiple specialties who are obviously interested in that, so digital people, coding people, national team, etc., etc. So we hope that that's comprehensive. We believe it is, but obviously we're happy to talk more and take on board if there are any gaps.
Yeah, no, it was just that I'd not been aware of that piece of work happening, so I'll link in with Peter Johnson and find out what's happening. If there's any input from our team needed, and that's what I wanted to make sure that we were aware of this piece of work and can share it with the other alliances. So yeah,
that's brilliant. Okay,
it's a fantastic piece of work. I'm really impressed.
Oh, thanks, Amanda. Yeah, it's Lucy and Lisa. It's Lucy James. No, Lisa James and Lucy.
Lisa James, yeah.
Yeah, so they've been doing the coordination, but we actually had the conversation with Peter to go through actually systematically all the all the codes that do not exist, to go through the rationale to why they should exist. So yeah.
Great, thank you.
And there's an ask in the chat for Afsana and Graham if you can share your email addresses. I think people are keen to connect, so I'm sure we can get them into the chat for you. So opening up for some further questions. So look, Karen Lees, do you want to ask your question, Karen?
Hi, thank you. Thanks, Sharon, for that information. That was really helpful. Yeah, I was just wondering if it's maybe too early, but thinking even more about the next steps of what can be done with data improvement. And again, I'm not sure where you are in NCL with this, but in terms of automatically pulling through even more of a referral form when it gets completed. And if that's something that you'd be aiming to do.
So Karen, so do you mean, I suppose, what do you mean, like the referral forms from the GP end, how much it's sucking up coded data? So So with the referral forms themselves, you know, do you remember they're sort of centric? Sandra, you know, the TCST used to hold that. Actually, I don't know where we are with who's kind of where the governance is with the forms, but for many years, almost a decade, TCST have been holding these forms centrally, and so the governance was that they would make all those changes. And in fact, before TCST sort of had been closed down, there was a recent iteration and a revision of these forms. So I think where they are now is pretty optimal. What our work is doing, it's not really targeting those referral forms. You know, we are saying that the information across the whole cancer pathway within the primary care context is suboptimal, and what can we do to improve that? I do see a future where things like this will then intertwine with what we're doing, but it's not on our kind of immediate to medium term kind of review. And as I said, especially because I don't actually know who's holding these referral forms and how in the future they're getting updated. So that's one that, you know, it feels like there's a conversation we need to kind of understand, you know, particularly with all the changing pathways and things like that. So, yeah, I don't know, Sandra, do you know what's the status with the
So I guess two things to say. I think that what the TCC did in terms of creating a single form for London was just London. So for people in other regions, I don't think that applies. And I believe that they went to NHSC and there's a website, but I can probably find out. But off the top of my head, I can't quite recall what the solution was when I left. But there had been a solution for the holding of those and the updating of those forms.
But then I guess, you know, like you said, Sandra, actually that's very London centric, but actually, you know, across the country. So there's so many other ways. And I don't know what it's like in your patch, Karen, how you guys update or even hold your forms. But that's something that is, or, you know, someone's job, but not necessarily mine at the moment.
No, that's great. Thank you very much.
Any other thoughts or questions or reflections from the group? Amanda?
Yeah, just a quick question. I wondered if there's any. Did you look at any other diseases or conditions where data coding was better recorded, or is this just? I mean, is it unique to cancer, or is it just it's the same with any kind of disease?
So the scope of our work was obviously cancer, but when we did the literature review, we had to lean on actually what is it like. So it's not the same, but then actually cancer itself, as the way we frame it as a disease, is really not comparable to diabetes or CKD. Cancer is not one disease. It's every part of the body system has a cancer attributed to it, and hence it's quite heterogeneous and diverse. My general learning from the literature review is that there are some pathways that have good examples of data completeness, and those are the ones that have good national drivers that mandate it. So diabetes is a good example. It has clear quality indicators and a clear QoF template that enables people who are involved in diabetes care to do that. So and that's, you know, that's really clear in the data. CKD is another one, and I believe, and there are some that have that actually are mandated from national audits, that they extract data as part of kind of national audit data. I can't remember off the top of my head now which ones those are. Maybe diabetes, there might be another one as well. So yeah, there are examples, but where there is no incentive, generally you see that picture of incompleteness and diversity. The hand up, Lauren.
Hi, hiya.
Hi,
Thank you. I'm Lauren. I work at South Yorkshire and Bassett Law Cancer Alliance, and I just a couple of reflections really. One, I wonder if the kind of upcoming technology around AI coding may make things a bit smoother, but a bit of work we've been doing in late effects has kind of revealed that we probably have a bit of work to do in cancer as well, in terms of standardizing our communications out to primary care. So we have had lots of circumstances where, say, end of treatment summaries are not completed, or they're incomplete, or they're inconsistent, and I wondered if we could, you know, it might be useful to look at some sort of kind of standardized end of treatment summary with a kind of coding summary, you know, like because I know from when I've worked in primary care and read and coded my own letters as a clinician, you know, you kind of you skim reading for the bits that you pull out, the kind of salient points. You certainly aren't reading, you know, thank you for referring this lovely 93-year-old gentleman. You know, it's you're looking for the codes, you're looking for the action screening, aren't you? And I wonder if there's a way that we could kind of work on that, because actually a lot of the people who are manually coding are administrators now more than clinicians, and actually are well trained to look for action. So if we could kind of use that as an opportunity to make things better as a kind of standard end of treatment summary, that we go, okay, this is the exact diagnosis that we want coding. These are the absolute actions, including a kind of recall system akin to other long-term conditions that then would get put into the system. And I think that might help that living with and beyond cancer, you know, follow up and kind of holding of the patient, and those risk factors for late effects.
Yeah, no, thanks, Lauren. Really, really good question. Something that's been, I know we've been talking about it in the last decade in London, certainly. How do we, so the challenges that we found, these are the big things, is that actually we don't even receive end of treatment summaries. The other big challenge, and some of you know this because actually there's similar challenges across London, which is the template that Macmillan actually created has never been implemented consistently across one cancer pathway, let alone across many pathways. And it's the usual barriers for us. And we again explored it through this work. It's every clinician has their own template, every department has their own template. It's all those people and IT dependent issues that prevent us, and which is why, you know, Graham and I always talk about we need a more systematic, non-person, non-human based solution, because we cannot depend on individuals retaining that memory of the right template. You know, we have to move away from that. So though, Lauren, I think it's, you know, all the things you've mentioned are really good ideas, but I feel like in our patch we have explored that and we just keep hitting that brick wall. And it's been decades, you know, now. So, you know, as well as not getting the end of treatment summaries, they're not coming in a format that anyone recognizes their end of treatment summaries. We do put it on our recommendation that we need to improve data transaction, even like you know, end of treatment summaries or even clinic letters aren't even presented in a way that primary care often recognize it, and they're given ICD-10 codes, and who can be bothered to convert that to a SNOMED code. But actually, as I said, you know, having done this a few times round and learned from already existing evidence base, we're like, this is just feels like and one of those interventions that we just need to park and say, let's just go for the machine. That's our view. But if you crack it, Lauren, obviously, you know, do let us know. Did you manage to hypnotize your whole cancer system and get them to
I'm not optimistic for that part. But it's good to know that I guess it's a problem that isn't just held by us.
No, it's a very well versed systematic problem.
Yeah, I would definitely agree with that. I think the more you can move it away from kind of human kind of discretion or error even, yeah, obviously the better the quality of the coding is going to be, and the more consistent. And it's the consistency, isn't it? That's one of the kind of key problems, I think. I think Amanda popped in the chat around the Macmillan template, so they do exist, but it's the utilisation of them and the adoption of them that's been the tricky bit, I think. Okay, any other questions or comments, reflections from the group?
Sandra, if I could ask the group, I mean, is anyone using anything remotely intelligent to fix the problem? I mean, in North Central London, we have got something called CogStack, which is deployed in various use cases in secondary care, but I don't know how widespread this is outside of London, or what the, I suppose, what the early gains are or the experiences are. That would be great if anyone has that sort of information. That's really where we're trying to head towards. Is there anyone? Doesn't sound like it.
No, it doesn't sound like it. Obviously, if we hear about anything, Afsana, we can feed that back to you. And certainly when we email the group with the slides, so people who weren't able to make the call, we can certainly ask that question as well. So
brilliant. Yeah, no, thank you. It's always good to kind of check, because these things, the landscape's constantly changing, isn't it? So
absolutely, very quickly, I think. Okay, Karen says not in West Midlands.
Yeah,
at the moment.
That's all right.
Okay.
I suppose the other thing then that I might want to ask, I know no one's asking me questions, is I might need to check. So one of the recommendations that Graham mentioned that we're like kind of imminently looking at is the opportunity that a federated data set brings. So building analytics into the solutions in terms of how you see whether MDFs are being implemented and improved. And I wonder, are other regions, are people building dashboards yet within their alliances, looking at metrics in primary care or across the system? Is that happening?
I think probably both. Mary, you might be to give a bit more light on this for West Six, but I think in quite a sort of limited way. So looking at specific parts of the pathway, like personalised care, for example, as opposed to anything broader.
Okay. And not necessarily primary care then.
No, I don't think the infrastructure is there to support it yet. I think even for cancer care review, where we're kind of reliant, well, we were reliant on the QoF data, and then probably much less now. Amanda.
Yeah, no, I was just going to say that I think it's mainly everybody was relying on QoF as part of their dashboards. I am aware that a number of cancer alliances are beginning to develop those personalised care dashboards, and they are linking in some of the primary care, but it would have, I'd assumed, been the QoF data, and as that's not being mandated now, it's probably going to, slowly decline even further than what it was. Unfortunately.
So we're trying to paint a picture where we're trying to reverse that decline, because we think the baseline, as we've showed you through evidence, is actually pretty poor. So let's see what we I suppose what we're really trying to do is use the different kind of angles and the different interventions that we've got to really, even though we're starting at a point where data completeness is really low, even if we build the dashboard, we use that as a propeller to then promote work around data completeness. So it'd be great to bring that back at some point, Sandra, to show you where we're at, because Graham and team will be imminently building something that is aiming to cover a lot of that. Majority of the MDS pathway. That's the aspiration, isn't it, Graham? So.
Karen, you've put something in the chat around UDAL, which I don't understand. So I don't know if you can explain that a little bit to us.
I have to confess it's not something I've been directly involved with. A colleague in our analytics team that, because again, as I think I'm hearing from a lot of people, we're looking to have access to that primary care data, using that to be able to inform targeted interventions. My understanding is that it's a national database, and we're actually just in the process of seeing if we can get some information sharing agreement set up so that we can access that data and then sort of pull that into a dashboard for it. Here in the West Midlands, we have 6 ICBs, so to be able to look at the primary care cancer related data there.
So that sounds not dissimilar to, I suppose, there are different way to call these things, aren't they? But Graham, I don't know if you want to. It sounds similar to what we're doing, aren't we, in our ICB? So
yeah, to an extent. I mean, UDAL's sort of national commissioning repository, NHS England, so all the commissioning data sets are held there. The trust submit to NHS England. So having access to that will give you a rich amount of sort of secondary care commissioning data. Not sure how much primary care is in there though. To be perfectly honest with you, we access our primary care through a sort of federated regional platform called the London Data Service, which is part of like the One London programme of work, which might be familiar to some people who have dipped in and out or are heavily involved in sort of care across the sort of London footprint. And our GP practices, like basically a snapshot of data is fed from each of our GP practices into what's called the London Data Service, which sort of federates all that together and allows us access to that primary care data. It's pseudonymized, it's shared at a patient level, but pseudonymized in the same way that the commissioning data is pseudonymized as well. So that allows that sort of linkage to allow you to link the primary care data to the secondary care data. But as we kind of mentioned earlier, we've really just got access to the London Data Service and that GP data set. So there's going to be a lot of, for the rest of this year, assessment of the quality and completeness of that. But yeah, UDAL will be a great start, really, just to be able to access the commissioning data.
Thanks, Graham and Karen. Okay, so I'm probably going to wrap up the meeting. Approaching 2 o'clock. Well, 2 o'clock, isn't it? Yeah. So thank you to Afsana and Graham for presenting. I think there's lots to kind of take away and think about in your presentation. And there may well be some more questions for you. So it's okay if I share your email addresses in the email that goes out to the group along with the slides. Brilliant.
Please do, yeah.
Okay.
No. Thank you for having us.
And we're very pleased to have you back as well once your, as your project kind of unfolds and you kind of achieve some of the things you wanted to do for your next step. So definitely be good to come back and tell us more about that, how that's proceeding, and perhaps there'll be more work happening nationally as well at that point. It's definitely, it should be a priority area for all of us, I think. Well, okay. Well, thanks everyone for coming. Our next meeting is going to be on the 9th of December. You should have an invite in your calendars. If you haven't, can people email me and let me know? We have had a little bit of an issue with looking at the meetings cancelled in some people's calendars. So if you are having that problem, can you email me? I'm trying to unpick what's going on. I don't really understand what's gone on with the tech. Other than that, thank you all for coming, and we'll be in touch with the slides and the recording when it's available. We'll see you again in December. And thanks again for the speakers and all your contributions.